So before I get started, I want to thank all the participants. For those of you who have not seen an ADKey or know very much what happens in it, but basically you take a lot of people from around the world, from various disciplines, and you put them in a room and you say, come out with something thoughtful based on some topics that we start with. And this is a very, very hard thing to do in a very short period of time. And I want to just talk about the fact that it's the people in the work groups that really create this, and me and my fellow co-chairs, John and Claudio, who this meeting would not have happened without them, get the opportunity to present the data to you. So basically, we know what the risk factors are. We have a good sense of what acute kidney injury to CKD looks like. And I think importantly, we have a very good sense now about these things impact outcomes, right? So we have a very good understanding what these long-term outcomes are. And this allows us to design clinical trials and hopefully design therapeutics, preventions, and other modalities to try and alter this. Now, where we are now is to think about this concept of these modifiers. Now, these are modifiers that occur that have been linked to acute to chronic kidney injury. Now, this looks nice in the sense that, okay, we know this exists. We know that severity is linked to acute kidney injury. But each of these areas also represent a hypothesis and a potential target. So if it is true that severity of acute kidney injury makes it more likely for you to go from acute kidney injury to CKD than a drug or a device or an intervention, perhaps something as straightforward as the KDIGO bundle and Alex Zarbach's paper on PrevAKI, should also then lead to less CKD. That would be a longer and larger trial, perhaps, but that's a hypothesis worth testing. If you alter the severity and incidence, you should also alter this. Similarly, if you start at a different level of kidney disease, and you can have differential impacts on severity and frequency of events. This is all about prevention, identifying a patient who has had AKI or CKD. If you decrease the number of events, whether it's a nephrotoxin or something else, you should be able to alter their trajectory. All of these are testable hypotheses. Similarly, if you can alter their duration, if you can enhance recovery thoughtfully, you should hopefully also be able to demonstrate that these things change. So I think it's important to recognize that as we put them up, this is not just a list to consider. These are all testable hypotheses. And similarly, if proteinuria is such a severe risk factor on both ends of the spectrum, we know that addressing this directly, at least in CKD, does lead to improved outcomes. So there was 4 work groups. One was assigned to define and work us through the notion of persistent AKI, and I'll explain what this is and why we chose to try and develop this. Acute kidney disease itself, renal recovery with a focus on recovery from renal replacement therapy, and drug dosing in acute kidney disease. So I'm going to start with persistent AKI and talk about the consensus statements that we've developed. But the key here is that we are really in an open white canvas. And in order to thoughtfully study AKI and now AKD, as Claudio indicated, we need to have harmonization of not just nomenclature, but also definitions. And so these are gleaned and integrated from the available data. And what we came up with for persistent AKI is that based on the available data, we've chosen 48 hours as the definition for which you have a form of AKI that's now going to be called persistent. This is all testable. Now, we all need to look forward into our data sets and do the work to prove that 48 hours is the appropriate criteria, and we do have data that suggests that. But we have to start somewhere, and we're starting with 48 hours. Similarly, in order to separate 2 separate AKI events, in order to have some harmonization, you require another 48 hours. And I'll show you some figures that may make this a little bit clearer. And lastly, this is a continuum. We're not suggesting that there's this abrupt moment where acute kidney injury becomes acute kidney disease in a pathophysiologic standpoint, but for purposes of definitions and being able to say what we mean and mean what we say, this type of sort of very careful definition is very important. And I'll show you some of the key recommendations based on that. Now, I'll show you more about acute kidney disease in a moment, but I just want to basically talk about the persistent AKI piece because this is important consensus recommendations in this development. And I think one of the key things that we've talked about is that the assessment of renal function during early AKI has not been well sorted out. And so we make some key recommendations about the utilization of eGFR equations, which should not be used if you're not in steady state. Timed clearances do have some supportive data, and I think we definitely need to do some work on kinetic and the Joliffe equations. But I would say that given the fact that we are now reaching the time where non-invasive technologies to be able to accurately measure GFR in the bedside of the ICU and in the ward are really very close to being available, I think I'm looking forward to the opportunity to have that at the bedside. But importantly, I think that the discussion about baseline acute creatinine is really important. And there will be scenarios where it's unavailable, and there are data on imputation and back calculation, but ideally you should really hope to try and have a value in the previous year at the bare minimum. Ideally, you have multiple values where you can actually take a look and get a sense of what the true baseline is. This is not always possible, and we basically stake this out in a rank order of what's preferable in the recommendations. But the reason that we felt the need to define acute kidney disease is based as follows. So we have a very good sense about acute kidney injury. Now, the definition for this, because of the original AKD definition, stops at 7 days. But we all know that people's injury and disease does not stop at 7 days. But in order for us to be able to thoughtfully study this, we need to be able to understand and have definitions that carry us through this gap between 7 days, which is acute kidney injury, and chronic kidney disease, which begins at 90 days. So in the original KDIGO statements, there is a reference to acute kidney disease that sits within this space, but it wasn't as well fleshed out as acute kidney injury or chronic kidney disease. And this was the opportunity to attempt to bring something more cohesive together, taking together all the information we have in aggregate between the space, and I'll show you what we've come up with. So the definition of acute kidney disease is the acute kidney injury that essentially lasts beyond 7 days. And I think clinically it's become very clear that this happens much more frequently than we initially imagined. The outcomes can be manifold. You can have another episode of AKI, you can have ongoing AKD, you can pass away, but this all changes at 90 days where you basically have to make a determination, do they have either acute and worsening chronic kidney disease or new chronic kidney disease. And this is really important because that definition is quite solid. It's not to say pathophysiologically that somebody at 95 days doesn't have ongoing AKD and their CKD didn't happen at 85 days. Recognize that these definitions are required so we can all be using the same nomenclature, and when we do studies, we can be using the same criteria. Now, the way we've operationalized this is to make it very congruent with AKI, and I'll show you this now. So this is the definition of AKD staging, and what you'll see is there's exact harmonization with the AKI staging from stage 1, 2, and 3. The difference here is that the urine output criteria are removed. So we're only looking at the creatinine criteria for stages 1, 2, and 3, and this harmonizes across both. But as Claudio has shown you, we also recognize that patients who recover or have apparent recovery may still have lingering injury or loss of renal reserve. And so we have a criteria which we refer to as stage 0 that has letters that allow us to try and ascertain that despite the fact that their creatinine has returned to below 1.5 times their baseline, they may still have ongoing issues that require follow-up or even potentially intervention. And I think a better way to see this looks like this. So what you see on the left is the classic AKI criteria, and what you can see is the AKD criteria, which move in time from 7 days to 7 to 90 days, match up exactly, right? So if you're on RRT and you're at stage 3, you continue to be on stage 3 to RRT at 7 days. So you don't have this entirely new set of definitions that you have to try and commit to memory. There's harmonization across. The same is for stage 3, stage 2, and stage 1. Now, we recognize that there's subacute acute kidney injury, but that subacute injury can carry forward in time beyond 7 days, so you have similar harmonization for the subacute aspect as well. And we've tried to make some clear definitions of loss of renal reserve and or ongoing damage by biomarkers, which I'll show you in just a moment. And so the reason why this is important, and I'm not going to talk at all about this paper, but John is after this talk, is that the way you recover matters. And so to give you a sense of why acute kidney disease as an entity is so important is that there's various trajectories of how you can have injury. So this is a patient who does not technically meet criteria for acute kidney injury. They don't break across stage 1 for 7 days. But clearly, this person probably was having subacute AKI. And this could be a patient who was on aminoglycosides for endocarditis as a potential example. You also have the opposite extreme, a patient who has severe acute kidney injury and does not recover promptly within 7 days and has this long, slow recovery after 7 days and somehow before 90 days. You can have another trajectory that looks more prompt like this, and these two things from a definition standpoint in just AKI would look the same, but these are two very different processes. Both these patients have stage 3 AKI, but they have very differential recoveries. And then you have the opportunity to see patients with a stuttering recovery. They get a little bit better, you think they're going to be fine, and that may actually be a period of time where they have two distinct episodes of AKI. Right? So this would then take into account our persistent AKI definition, where they have an initial AKI event, and then they begin to recover, and then they have another event, or they have an exacerbation of the ongoing event. And then you have a patient who may promptly recover. So within this definition system, we're able to account for all of these trajectories in a systematic fashion. And this is what that exact figure looks like in the paper, although it wasn't animated, so I had to redraw it. So basically, we know that if you have acute kidney disease and you're in this period between 7 and 90 days, that you can evolve subacute acute kidney disease. And we know that there are different ways that this can happen. So Nish Panu did a large population data set which demonstrated that even if you recover to less than 1.5 your baseline creatinine, you still have ongoing mortality risk until you drop down to 1.15 or within 15% of your baseline. And so this allows us in stage 0C to look at patients whose creatinine has not returned back to baseline but is still below the stage 1 threshold. Similarly, we know that patients who have elevated NGAL or nephrochecks that are below the stage 1 threshold are at risk long term. Well, we also acknowledge that there are likely biomarkers, and maybe these biomarkers or others, that identify ongoing subclinical AKI. But since that definition changes from day 7, that would then continue to be subclinical AKD. Now, there are patients who may recover their creatinine completely, but we know that patients who recover their baseline creatinine completely may still have ongoing risks, and these patients may still need to be followed. So technically, these patients will be considered recovered, fully recovered, but from an epidemiological standpoint, these patients may carry risks, and in the future, we may be able to identify them. So this is set up to be much of a placeholder to continue to study these patients. Now, I think it's important to recognize that many patients, and the strongest weighted risk factor for acute kidney injury is CKD. So many of these patients will essentially have chronic kidney disease, have AKI, they may have a new form of AKD, and that superimposes on chronic kidney disease. And so even though we've presented this very nice linear setup with subsets that we can look at, whether it be not returning back to baseline creatinine or ongoing biomarkers, or not having evidence but still having risk, we recognize that this nice linear setup is not always going to be there for all patients. This is a very nice unidirectional setup for a patient who has normal renal function, gets acute kidney injury, doesn't quite recover, has acute kidney disease, and moves to CKD. But we know that there'll be a lot of back and forth. Right? There will be patients who have CKD, they have AKI, and they'll go backwards and forwards. And being able to codify this for every single person in a single definition scheme, you can do with what we have proposed, but recognize that if they come to the table with CKD, that previous baseline sets them for all the new definitions that we're utilizing. And then we decided to try and give some recommendations on how we might want to follow these patients. And in very simplistic terms, it's a layered cake, which is to say that the worse your AKI or AKD stage, the the higher intensity of follow-up you'd likely require. So if you have stage 1 and you recover, then you probably just need some education, and your physicians should be thoughtful enough to make sure that you don't get exposed to other severe nephrotoxins or other events. And I think this requires more study, right, and more scholarship to understand if you have an event, do you become at risk for, contrast in the future? And so I think it's important that one of the simplest things that we do is that if someone has an episode of acute kidney injury, it at least makes it into their medical history, right? I mean, if someone had an MI previously, that's an important finding in their past medical history. We need to offer up the same level of scrutiny for patients with acute kidney injury. Similarly, if you have stage 2, the level of follow-up is more intense, expectations of what can happen, and hopefully we will have therapeutics for these patients. And I think that we can say with a lot of confidence our strong recommendation is that if you have stage 3, and especially if you've been placed on renal replacement therapy, you should have nephrology follow-up. I think this is critically important because these patients clearly are the ones, even if they recover from dialysis, who are at risk downstream for not just CKD, ESRD, but repeat hospital admission and getting into trouble, particularly for heart failure and other major adverse cardiovascular events. So the consensus statement for recovery from renal replacement therapy, we don't have any hard and fast recommendations. I just leave this here for you to take a look at. But basically, we set an arbitrary recovery of 14 days. That this is the point where you're considered to be independent, and then if you go back on dialysis, it's considered a new event. Whether it should be 13 or 15 or some other prime number, and we're not trying to discriminate against prime numbers, but we had to make a decision and pick a number, and we chose 2 weeks because clinically that's reasonable. We review the literature on different modalities and different techniques of what's available. We don't make strong recommendations on either mode to guide recovery, whether it be intermittent, SLED, or CRT, although I can assure you there's many strong opinions about both of those in the group. So for recovery, we do not have specific recommendations, as I mentioned, and hopefully we'll be able to glean more from this, some of the new clinical trials that are currently ongoing. And I think that it's important to recognize that we don't have good process of care measures at this point to make recommendations on how best to facilitate recovery. The last group focused on dosing of drugs and how, not just to remove nephrotoxic drugs, but also a thoughtful assessment about when to reintroduce drugs. So imagine you have a patient who has heart failure. They're on an ACE inhibitor. They need that drug for their underlying disease, and they have a severe episode of acute kidney injury. Now the ACE inhibitor comes off. Well, when do you reintroduce it? Do you introduce it as they're just beginning to recover? Do you wait for them to go home? Do you do it beforehand? And so there's a large series, which I'm not going to go through the tables, but I'll show you at least one figure, that discusses these kinds of notions about patients who are on drugs that can become problematic, especially in acute kidney injury and acute kidney disease, that do need to be reinitiated, and how do we go about doing that in a thoughtful fashion. And I think that there's a set of criteria that's offered on how you can basically develop potentially a checklist to make these decisions. And so I'm not going to read these slides to you, and this is available in Nature Reviews currently, and it's a free download. So one of the key consensus statements here is that while it is certainly true that you should avoid all nephrotoxic agents, I think it's critically important to recognize that there's negative synergy, if I can use that term, between nephrotoxic agents that conspire against the kidney. So looking at multiple drugs and looking at evolving drugs whose nephrotoxicity is being newly evaluated, like PPIs, which we thought were very benign, but more and more so it's becoming associated with acute kidney injury and chronic kidney disease. And so this is a cartoon that basically gives you a notion about how to consider these patients for biomarker and GFR measurements through their course of acute kidney injury and acute kidney disease. And as they go further along in their course and their GFR is more compromised, then you have decisions regarding withdrawing drugs and active medications, assessing metabolites, and then importantly, as I mentioned before, when do you begin reintroduction of drugs, and when is it important, especially for drugs that are very important for the underlying disease of the patient in question. So in summary, the new ADKI 16 guidelines propose definitions for persistent AKI and acute kidney disease. We've attempted to make this as congruent and consistent with the previous AKI guidelines to manage harmonization, but it also allows us to study patients within this time period now, and we will now get busy, and I hope many of you will join us in testing some of these definitions to see if they hold up to scrutiny. There's also guidance on recovery from renal replacement therapy and for management of drugs. Thank you.